You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to episode 457 of the podcast. And in this one, I got on Jon Hershfield. Jon is a many-time guest on the podcast, so a lot of you will be familiar with Jon's work. Jon is the director of Sheppard Pratt, the Centre for OCD and Anxiety. In this episode, we discuss what is a residential treatment centre, who can benefit from residential treatment, what a day in the life in residential looks like, the duration of a residential stay, therapy at residential centres, art therapy, yoga, mindfulness, having a team around you, the use of family therapy, and much more. So if residential therapy or treatment is something you've been considering, hopefully this episode helps you. If not, we talk about other topics like mindfulness and the importance of other therapy styles and activities in the approach to recovery. And thank you to NoCD for supporting the podcast. NoCD offers effective and convenient therapy available in the US and outside the US. To find out more about NoCD, their therapy plans, if they currently take your insurance, or to download their free app, head to go.treatmyocd.com/the OCD stories, or the link will be in the episode description. Thank you to all of our patrons for supporting our work. To sign up to our Patreon and to check out the other benefits you'll receive as a patron, please see the link in the show notes. So thank you to you guys as always for listening. It really means a lot, and wherever you are on this planet, I hope you are doing well. And thank you to Jon as always for his time and expertise. I really appreciate it and enjoy chatting with him. So without further ado, here is Jon. Welcome back to the podcast, Jon.
Thanks for having me. Good to see you again.
Yeah, it's good to have you on. So just an update for the listeners, how you been, what you've been up to, anything you want to share?
Yeah, I've been well. Thanks for asking. It was nice to see you in Florida at IOCDF. Glad you made it out without COVID. You were one of the few and proud. Things have been good. I've been working very hard at Sheppard Pratt. You know, I run this outpatient center for OCD and anxiety, and we also provide all the OCD and anxiety services at the retreat, this adult residential psychiatric program, which we'll talk about today. And I'm just really proud of the work that we're doing, and I'm glad that my job isn't boring. You know, it's you could settle in at some point in your old age and just sort of do the same thing over and over again. And I can't claim to know how each day is going to go, and sometimes that's challenging. But for the most part, I think it's a really good thing. I'm lucky to have.
Yeah, no, that's really good. It's good to be challenged. And are there any books in the works or anything like that?
I'm going to keep that a big secret because I don't know the answer. I've been developing a concept for a book and considering whether or not I'm ready to write it. And if so, you know, am I ready to write it now or later? I feel like I have another book in me, but kind of tied back to the previous discussion, I have to pay attention to the number of hours in a day and where I'm going to devote them. So I'm not retiring from writing, but I'm not promising when the next thing is going to come.
Okay.
But I do have an idea in mind for what I will write.
Okay. So it's probably coming, just the timeline is TBC.
I think that's probably fair. Yeah.
Yeah. Okay, cool. Nice. Well, let me know when you do, and we can cover whatever it is. Assuming there's an OCD element, we can...
I don't know a lot about other things, so I think you'll have to get more OCD stuff. Yeah.
Good. All right, cool. So yeah, today we're obviously going to talk about the residential program at Sheppard Pratt. We've talked a bit about residential programs here and there on the podcast, but it'd be good to give a bit more of a deep dive and also just talk more generally about what you guys are doing at Sheppard Pratt. So I guess first of all, for those that don't know what we mean by residential program, how would you describe that?
Yeah, I wouldn't have claimed to understood it until I worked here. I mean, it is in the name, but it's hard to kind of wrap your head around until you really see it. So it's residential, which is to say that you reside in your treatment. You live where you're getting treated. So when you think about the different levels of care, There's traditional outpatient, perhaps 45 minutes a week would be a standard, once a week appointment kind of thing. Then for maybe people who need a little bit more support, they might do something like an intensive or an accelerated thing where they're seeing their outpatient a few times a week, or a traditional IOP, intensive outpatient program, which would be 3 hours a day, usually for a few days a week. Sometimes people do what's called a PHP, a partial hospitalization program, where you're going to a program for the better part of the day, and then you're going home, maybe 6 hours or so. And then there's this thing called residential, where 9 to 5 you are in therapeutic programming, and then 6 o'clock you're having dinner with your other peers in the milieu who also are living at the program, and then maybe there's some activities, and then you're going to your room and you're sleeping and you're waking up and you're doing it again, and you're really kind of devoting all of your attention as if it were a full-time job and more to your mental health care. And I think it's important to make a distinction between residential treatment for OCD and related disorders and what's sometimes called inpatient, where you're being admitted into a hospital where you are also living, but the circumstances there are a little bit different. In an inpatient, the emphasis is maybe going to be a little bit more on the urgency of your safety, stabilizing your medications. It's not to say that you're not getting therapy there, but the therapeutic environment is a little bit different from what you would see in a residential program. It can also be inpatient, can also be sort of voluntary or involuntary. So where I work at the retreat, it's a voluntary residential program. People choose to come here. They decide in collaboration with their doctors and clinical team when they want to leave and what their next step will be. In inpatient, there's also some additional things that, because they're only working in extreme kind of acute situations, there's limitations in terms of communication, what things you can have. We, of course, have certain limitations here as well, because it is in a hospital environment. We want to make sure we keep everybody safe, but it's much more flexible than you would get in inpatient.
Yeah. Okay. So inpatient, there's much more risk to self or others, and we need to stabilize the person before they can engage maybe in therapy. Whereas residential, I'm going there just to get more intensive therapy, but I maybe have a lower level of risk to myself.
I think that's fair to say. I mean, we do certainly work with people who have recently found themselves in danger, with attempts on their life or self-harm or things like that, or they may have recently come out of a psychotic episode or something like that. But yeah, I think you could kind of look at inpatient as a way to help someone in a very acute stage get to a place where they would be more capable of participating in therapy, in a therapeutic environment in a sustained way. And so sometimes we have people here who, they're doing well, they're working really hard, but something goes awry, and we can't support them at the level that they need to support it. And so they might actually leave the residential program to go to inpatient for a brief period of time and then come back. That does happen sometimes.
Okay. Good. Thank you for that. So, I mean, you've kind of answered this, but I'll answer it more directly. If people are listening, what am I trying to say here? I guess, who needs residential treatment? Like what state do I have to be in, or what level of need do I need to go to residential?
I think it's a very personal decision. I think some of the factors that go into someone deciding to come to a residential level of care would be those first factors that we talked about, where it's sort of like, I really don't know that I am safe. I'm not obviously in danger, but I'm having a lot of suicidal thoughts, or I'm not able to contain my self-medication with substances, or I'm having I can't continue to work, or I'm not able to get some of my, it's like I get some of my basic needs met. It's I can kind of more or less get up in the morning and go to bed at night, but I'm not taking care of my ADLs and, hygiene, things like that. And there's, I know I don't have what I need to be able to just kind of go to therapist, get some help, come home and practice that help. I need something more than that. Other reasons that people might go to residential program include, having tried lower levels of care and just not being able to make a dent in their OCD, despite how hard they've tried. And the clinicians that they're currently working with are saying, like, listen, you need more engagement, more eyes on you. I think the biggest reason I see people coming here, at least through the OCD lens, is that there's more than OCD going on, right? It's not just some people do come here, just for severe OCD, but when you live with severe OCD, it invites other problems. It's a condition that can be a magnet for other problems. Your listeners know you can't function with really intense, severe OCD for a particularly long period of time before developing symptoms of depression. Or if in certain kinds of OCD, you may find yourself getting so rigid with your rules and trying to obey the OCD that you lose sight of what's a compulsion and what's your character or your personality type, and that can be really difficult for your relationships. So, people develop, issues like personality disorders and things like that. And also very common is people have other co-occurring conditions that they're unaware of. And so they're just treating the OCD, and it hasn't been revealed to them that actually they're struggling with bipolar disorder on top of it all. And that's mediating the intensity of the OCD. Or there's unprocessed trauma, and they're dealing with a complex PTSD scenario, and their OCD is kind of helping to protect them from getting re-traumatized, but it's like repeatedly kind of cutting off the mushrooms that are coming out of a soil, and the soil is not being addressed. So it's that kind of complexity that I think lends itself to a person deciding, I'm going to go to a program where, I'm going to work on my OCD, and in that I'm going to be doing CBT and ERP and ACT, but I need emotion regulation skills from DBT, and I need my meds to have another, look at, see if there's some changes to be made there, or maybe I need ECT, or maybe I need TMS or some other intervention for my mood. And also I need to learn how to get along with people again and how to relate to people again in a group environment. And so I want to be in a tribe, right? So a milieu and residential program is a kind of created tribe, like, hey, you're here, I'm here. Right. And that's going to look a lot different from what your home life might be or what your life at work might be if you're really getting hammered by OCD and another condition.
Yeah, that's a really good point. So I guess before we go into the therapy side of things in a bit more detail, let's say I've decided to go residential. It's either my first day at Sheppard Pratt or the induction meeting, whatever you call it, where you're going to tell them when you come in 2 weeks, this is kind of what to expect. For the listeners, what would a week look like, or a day in the life of someone in a residential, for you guys at least, look like? And what sort of stuff's going on?
So I'll kind of throw out the disclaimer that I'm not going to perfectly represent, first of all, obviously the experience for everybody, but also I'm kind of mindful if I work for this institution, I'm sure I'm going to miss some steps because I'm not personally involved in every step, but I can kind of give you a sense of what I've observed, which is, when people arrive, they often come with a family member or somebody, to support them. And they will meet with the admissions team, who will kind of introduce them to the first people that they'll meet. They'll meet with nursing staff. At different shifts, you're assigned different nurses, but there's always that sort of go-to person that you can rely on. There's always somebody who's there for you. In your first 2 days, and typically in your first admission day, you'll meet what's called the attending psychiatrist. So this is the medical doctor who is literally signing the paperwork saying, I'm admitting this person to this program. And they're going to be the one at the end of the day to sign the papers or saying, I am discharging this person from this program. So they're kind of at the top of the pyramid. And in our program, which does stand out from the models used in other programs, the psychiatrist is heavily involved in the psychotherapy, heavily involved in the treatment. So not functioning primarily as a med manager, but as a major feature of the clinical system. So they will do their evaluation. Our social workers will do their psychosocial evaluation, kind of get some more background on where you're coming from, what you're needing, what your expectations are for when you leave. And if you're coming in with OCD or something like it, then myself or someone from my team will also do our thing, with not dissimilar from what it looks like in outpatient, where I'll sit down and see, what are you doing here? How did you get to this place? What are your, what are you struggling with? How can we help? And then we'll work through a list of OCD symptoms. Do you have this, or have you ever had this symptom? Do you understand what the symptoms look like? We use the dimensional obsessive compulsive scale as our measure. So we ask a lot of questions about contamination, fear of harm, unacceptable thoughts, just right, things like that. And, how much time is this taking? How much are you avoiding? How much impairment is it causing? Things like that. Then we sort of as a team collaborate. So, myself, members of my team, the psychiatrist, kind of everybody gets together and says, okay, what's the formulation? What do we think is going to happen with this person? What's the diagnosis? Diagnosis can evolve. Someone can come in and be like, oh, this person's just like all OCD all the time. And then we learn later, well, actually there's underlying trauma, there's bipolar, there's some other condition going on. That's the beauty of working in a team. And that's another reason to come to residential. Like I said before, right? It's different than when you just go to one therapist and you have that one therapist's mind looking at it through that one lens. So it can be a lot, as you can imagine. You're going to be nervous coming in. You're going to be living in a space that's not your home, and we want to make it your home for the time being. So everybody here has their own room, so you'll be shown to your room. Have to have a belongings check, make sure that you're not, bringing in anything, even unintentionally, that we really can't have in an environment like this. Checking any meds you might be bringing with you and things like that. And then, pretty much you're given your schedule, right? And then each morning you have your schedule, and it's going to say, okay, 9:00, you're going to be meeting with the doctor. At 10:00, you're going to be in this group. 11:00, you're going to be meeting with the OCD team. 12:00 is lunch. 1:00 is DBT. And it's a very full day, and it's very much, listen, you're doing the best you can. We'll meet you where you are. And also, this is the full-time job that we hope you'll be able to really kind of engage in, and you're going to leave here suffering less than when you got here, and with a lot more answers. So sometimes, like I said before, people are coming really needing diagnostic clarification. And sometimes people are coming like really ready to do the therapy, to do the work that's going to really change their life, turn their life around. And, the best outcomes are people coming for both.
Yeah, absolutely. And I'm sure, again, this is maybe how long is a piece of string, but what is the sort of timeline of residential?
I love that statement. I never heard it. How long is a piece of string? That's a very Zen question.
You never heard that?
Yeah, that's new for me.
Maybe it's a very British thing.
How long is a residential stay? I mean, at our program, we start with a minimum of a 20-day commitment.
Okay.
And about 2 weeks in, we have what's called the diagnostic conference, where the representatives from the different teams that are working with you kind of sit down with you and say, like, here's what we think is going on, here's what we've observed, here's what we've done so far, and here's what we recommend moving forward. And I think the average stay is somewhere between 30 and 40 days, but many people will stay much longer. I've known people to stay 6 months, 8 months. I think for the average person, right, and that's not to say for every person, but for the average person, there's some critical mass of time that you can be living on a hospital campus before you start viewing yourself primarily as a sick person. And that sick identity becomes another problem that has to be addressed. So we wouldn't want somebody to stay only because they're afraid of moving on to the next step, or only because they don't view themselves as capable. But that's part of the therapy work, is like kind of gradually helping someone realize how they can take ownership of their mental health needs. It's especially true in OCD, as you know, Stu. Like our model is really teaching people how to be their own therapists and take care of themselves and stand up to their OCD. I think one of the things that we that we offer that's very helpful is our group home system. So many people come to the retreat after they've done the bulk of the work here for however long it is, whether it's 3 weeks or several months, will then move from this hospital setting to a house. We have a couple of houses that are maybe about 15 minutes or so from the campus here, and they are going to be living there with half a day of scheduled treatment as opposed to a full day. And everybody that they're living with in the house are alumni from the program. So it's people they're familiar with. So there's the milieu is kind of already built in. Yeah. But, they have things, they have to start, dealing with their own food in the kitchen and taking care of other things that might have been taken care of for them in this environment. And with that extra time, they're still working with their team, they're still going to their therapy appointments, but they're also doing occupational therapy and kind of getting back into school, maybe part-time, or they're getting back into work or volunteering and sort of starting to step out into the world a little bit before they're then kind of released back into the wild, as it were.
Yeah, I like that. That's smart.
And there they might stay for, again, how long is a piece of string? I mean, they might stay for a month or they might stay for a year. It really kind of depends on what their needs are.
Okay, nice. And so I'm assuming, obviously, it's not segregated by your primary diagnosis as OCD, so you're living with OCD people. I imagine it's all blended. And if that's the case, in my day of scheduling, obviously I might see you, Jon, or one of your therapists for OCD, and then I might have the DBT skills. For example, in the DBT skills group, let's say, am I with people with personality disorders, maybe psychosis, maybe bipolar? Is it really mixed, or do I stay with OCD people throughout?
So we do have a mixed milieu, but there is programming that is more focused on OCD. So we have a couple of OCD support groups, for example. So those would be attended only by the people who would benefit from it and not by the whole group. But something like a DBT group would be advantageous for everybody to go to that, because everybody who's going through a difficult time, whether that difficult time is coming from difficulty managing your emotions from as a result of a personality disorder, or difficulty managing your emotions from OCD or mood disorder, managing your emotions and being able to be mindful of them and know how to downregulate or tolerate distress. Those are skills that we all need. I was worried about this when I came to Sheppard Pratt and was, invited to provide OCD programming in this environment. Like, people with OCD, they don't want to be in an environment with people who have substance use disorders. They don't want to be in an environment with people who are, maybe coming down from hypomania or something like that. And I was just very pleased to see over the years that what I thought was going to be this kind of segregation and like, well, I don't want to be in a place where I can't relate to people. It's actually the opposite. It's been very interesting to observe how quickly people are able to say, to see, oh, you suffer, I suffer. You have a family, I have a family. You have a dog, I have a dog. We're really not that different. We might have different diagnoses that require slightly different treatments, but I think there's something, it's interesting in OCD. I've thought about this a lot. Like, the OCD community is a really special thing. I think it stands out from many other mental health communities. You go to an OCD conference, for example, and it's just this beautiful thing of everybody's like really connected and together, and they're rallying around these concepts of how we're dealing with intrusive thoughts and what's it like to have OCD or be in an OCD family. And so that's a good thing. But I also think siloing yourself away from people who struggle with depression or people who struggle with trauma can also make you feel more isolated. You can also inhibit your ability to treat your OCD, because then you're not looking at yourself as somebody who's simply suffering and needs tools to reduce suffering. You're looking at yourself with this very specific problem that has this very specific treatment, and I'm not getting better, so I must be bad, So I found that the mixed milieu environment, although occasionally there's glitches in the system, not everybody gets along all the time, I found that it's actually provided a sense of warmth and comfort that, again, I wouldn't know because I don't work at another system, but I could imagine if everybody had the same problems, it might not necessarily be better than what we've got. I think we've got something special here.
Yeah, I think you're right. I think when the community is great, the OCD community, but I think you could probably get lulled into a sense of, oh, only people with OCD get what I'm going through, and someone with bipolar might not exactly get what you're going through, but they know what it's like to suffer. And I think maybe when you're around these people more, you kind of see that shared humanity, that we all kind of suffer, just in slightly different ways. And there might be more, then you, I guess what I'm trying to say is you can get more comfort from more people, not just people with an OCD diagnosis.
Yeah, and you can develop self-compassion by developing compassion for people who are different from you. Like, that's part of the work.
Yeah, good point. So I guess speaking on self-compassion, and maybe, is there like, we've talked about the different therapies that might come up, and obviously I'm sure there's a lot you haven't mentioned that would be therapy groups and stuff like that, and maybe support groups. Are there, like, within the day, is there like yoga, like stuff like that that's interwoven in?
Yeah, absolutely. So we have, for the people who come for OCD, what we do is we sort of bend the program to their specific OCD needs, right? It's not always the case that more OCD treatment is better OCD treatment. So people might come here with severe OCD, but given the complexity of what else is going on in their kind of constellation of mental health needs, something more than, one ERP session a day or every other day, would really just be overwhelming. And then there are others who come where, their OCD is pretty severe, maybe not as severe as the person I was just talking about, but is of a type where, repetition is of the essence, is essential. So that person we might see 2 or even 3 times a day for, dedicated ERP sessions. And so we'll be kind of pulling out little bits of their schedule that are open, or maybe we'll pull you out of a group here or there if we think that's necessary, to kind of give you, the general retreat experience, but modified for your specific needs. Without that element, the schedule will, include, beyond your meeting with your psychiatrist or your other members of your team, exactly what you said. So there'd be DBT, there'd be yoga, mindfulness, art therapy plays an important role here. There's recreational therapy, a couple of different psychoeducation groups, for example, on trauma, CBT, things like that. We also have, community activities and outings, right, on the weekends. So you can sign up to go to the Baltimore Aquarium or something like that with the group. We have weekly dinners at the group home, so people who are residing here at the retreat can go see what the group home looks like, and they do like a big cookout or a bonfire or something like that. So we really do try to make it feel like a community and like a home, and not just like a place you have to be because you're struggling. And again, it was one of those things where when I came here, I thought, art therapy, like whatever, like it's all about the ERP. And I'm just really pleased to see how wrong I was, because art therapy can often play a huge role in treating OCD. And I don't mean just like doing exposure to, painting scary pictures or something like that, but being able to express what it's like to be you without language. I mean, so much of OCD is language oriented, the words that are going on in your head and the way you're interacting with those words. And to be able to just present outside of your head something like, this is what it feels like in a non-linguistic way, incredibly therapeutic, and gives you some meaningful weaponry against the OCD, the ability to sort of stand up to something in the OCD beyond just what the OCD is saying. I've found that the art therapists have done a really good job here of connecting the dots for people, the sort of missing puzzle pieces.
Yeah, I'm really glad you said that, because I will bring elements of art therapy into my work, because especially as I work with kids, obviously art therapy is for adults too. I'm not an art therapist, but the small bit of training I had on it, I do bring in, and it's good to get creative in that way, as you're saying. And I also use sound play a lot now with my kids and teens, because like you're saying, they can express without words and explore and face stuff and try and understand things in a different way that maybe our language just can't comprehend at the minute.
That's great. Yeah.
And OCD doesn't, sorry, go on. was going to say, I don't think OCD, thinking about the sand trays I've done with clients of OCD doesn't get involved in the sand tray. Like, I can't think of a single time, at least that I've noticed, that OCD has messed up a sand tray. So it's almost like, I don't know, the walls of the sand tray block out the OCD. I don't know what it is. So I think it allows people to explore and express without that voice in their head as much for that 20 minutes they're doing it or whatever.
That's really interesting. Yeah. I mean, I think, and we see that in art therapy here too, where maybe somebody struggles with over control or perfectionism. So the art therapist will know, hey, let's intentionally use some kind of material that's a little unwieldy, watercolor or something, or somebody is, especially connects better with something that's more sensory, and less intellectual. So let's intentionally work with clay or something, on your hands. Like that. So you mentioned also yoga and mindfulness. I'm a big mindfulness guy. I think it's so essential to OCD treatment and making ERP effective, to be able to be a witness to the learning process and not just kind of white knuckle your way through it and, wake me up when it's over, So we have a really great yoga instructor here, and we kind of bring her along with a lot of the OCD groups. So the sort of OCD centric groups typically will start with a meditation of some kind or a mindfulness exercise of some kind. I also run a mindfulness group here, which is a lot of fun. So I get to kind of come in and we'll do a little meditation. We'll say, well, what's this about? What's it mean? And then we'll get to kind of workshop, like, well, what does it actually mean to be mindful? Like, what's keeping you from being in this room right now? I get to kind of discuss it with the people in real time. And I get a lot of joy out of seeing people kind of connect the dots of like, I can be an observer of what's going on, and then I can respond. And again, what are we talking about? We're talking about cognitive behavioral therapy. It's like looking at your thoughts differently so you choose healthier behaviors and you're not driven exclusively by your emotions. It's all mindfulness. So we have these sort of dedicated mindfulness groups, but of course it's also woven into the whole experience, because you're also doing ERP with an awareness of mindfulness, and you're also eating, hopefully, with awareness of mindfulness. So it's a common thread in it. Where doesn't it apply? Right. Some people, it might be more effective for them to be doing external mindfulness, like focusing on, what you see and what you hear, whereas others might do better doing an internal mindfulness, like, noticing what arises in your consciousness. Mindfulness can be modified to get the results based on the person. It's not a one size fits all, but I haven't met a person for whom mindfulness would not be something to consider in their treatment. Right.
Yeah, I think that's useful to hear, because obviously a lot of people might say, well, I tried it, didn't help me, or it triggered me, and sometimes it's just finding the right tweak and combination, and I guess, as you're saying, understanding it in the right way for it to sink in that, okay, now I get it and I can practice it.
Well, the fundamental source of the suffering, separate from obvious things like medical conditions or neurochemical issues or things like that, right? Why are you suffering? You're suffering because there's a belief or a story, there's an idea in your consciousness, and you're attached to it, and you don't like it, and you'd rather not be attached to it. But when you try to detach from it, things don't seem to go your way, and you get overwhelmed, and you go back to that story, and you keep trying to fix it. That's how OCD works. That's how depression works. That's how trauma works. That's how pretty much everything works. And so the ability to notice the difference between being lost in thought and attached to a story and immersed in a narrative and actually experiencing reality in real time, that's what we're all striving for. You don't have to have a mental health issue to have a problem with that. So when people say I tried mindfulness, it doesn't work, what they mean is they tried meditating and the way they were doing it didn't feel right for them, or maybe made them feel worse or something like that. That's totally relatable. But it's kind of like saying, I tried physical fitness and it doesn't work, right? It's like, well, maybe powerlifting isn't for you, right? And maybe cardio isn't for you, but there's got to be some way of connecting with your body in a healthy way that would be for you.
Yeah, 100%. Yeah, that's a good description. So, I mean, you have kind of talked about this a bit already, but I guess I just wanted to explicitly ask it, which is, as a client, a patient, how am I being kept in mind, if that makes sense? Like, at what points throughout my 2 week stay, let's say, 3 week stay, are people talking about me, and how often is that happening? And I mean that in a good way, like you're coming together to strategize and do all that.
That's a really interesting question. That can be difficult for some people when they come here, to tolerate not being able to keep too many secrets, because it might be what they're used to in their personal life. So, in a residential program, in this program, there's 24/7 nursing care, for example, right? So you're being checked on every hour. The nurse is responsible for knowing where you are and how you're doing, the nurse on that shift. And when you're, needing to take your meds, it's the nurse who's going to be providing them for you. And when you're having a rough time and you're feeling like, I don't know what to do, and you're not in the middle of a particular session working with a clinician, it's the nurse that you're going to go to, and the nurse is going to tell the team, like, hey, your patient was struggling with this. We use these coping skills. They're worried about this and that. And then you have your psychiatrist who's meeting with you anywhere from 3 to 5 days a week, and so they're seeing you very frequently. And then you have myself and my team who's seeing you pretty regularly, and we're constantly thinking about you. Like, I think it's easy to overlook, like, oh, they're just kind of letting me go to the groups and they're hoping that it works, Yeah. But I guess, for lack of a better word, I'm obsessing about all of these patients. Like, how are they doing? Are they making progress? Are they doing well? Oh, they're having a hard time. What was causing the hard time? Is this a hard time that's part of the process, or is this a hard time where we want to make a change to how we're approaching them so that that's not getting between them and their wellness? We meet as a broader team on a very regular basis, and then we meet in mini teams on a regular basis, right? So we have like the whole staff that meets, let's say, once a week, but then the different sub staff, the nursing teams and the psychiatrist teams, they also have their meetings, and my team also meets several times a week. And then in many cases, we will also have micro teams of like, okay, OCD and the family therapist and the doctor are going to get together, an additional one time a week to just make sure we're all on the same page.
Yeah.
Because it's a lot. And look, you don't have to have borderline personality disorder to find yourself splitting and sort of idealizing and demonizing different members of your team. It's part of human nature to say, I like this person, I don't feel safe with this person. And when you're working with many, many different people at the same time, we have to keep our eye on that. Like, it's okay that you have different relationships with these different people, but do you also have a relationship with the system? And does the system feel like it's supporting you? And we are creating a family system for you here. So the short answer to your question is, we're thinking about the patients constantly, and we're talking about them and how to help them pretty much constantly.
Yeah, that's really good to hear. And you mentioned family therapy there, and it's something I've been thinking about recently within my own practice of when to refer out to a family therapist. So I've seen it, again, I mainly work with children and teens, and I might see that usually the teen more so than the younger kid, there's certain issues going on in the family, the teen's button heads with the parents, the OCD's obviously driving that, as well as brain changes and development in that period of their life. And sometimes I think the butting of the heads between, say, mum and kid or dad and kid is interfering with the work I'm doing. So sometimes I feel the urge, I need to refer out here to a family therapist for a little bit before we continue. So I guess I'm just curious how family therapists help within the cases you've seen with OCD, and what sort of uses you see for them.
Yeah, so it's funny, actually. I was talking to a patient yesterday about how some of their beliefs that drive their OCD sound like they've come from their family system. And I was using a lot of systemic, language. And at the end of the session, they were like, are you like some kind of family therapist or something? It's kind of funny because people don't know me as that, but I am an MFT. And so that background is really useful. So, we try to think about people systemically from, people don't just sort of show up with problems out of nowhere. We try to view people in their context. We have a wonderful family therapy team here. So we We typically do involve family therapy when the patients allow. They don't always necessarily want it. But if it's something where they understand that it might benefit them, then they'll engage in it as well. It's one of the challenges of doing family therapy in a setting like this is the patient is here and the family is there, right? So it's, maybe it's a spouse or maybe it's parents or adult children or something like that. And the concept of the identified patient kind of goes out the window because they're the patient who is identified who is here and they're there. So we can't really change that model the way you might in outpatient family therapy, where you're kind of looking for who the identified patient is and who you're actually going to work on. Well, no, I mean, these family members really want to know that their loved one is being cared for. They want to understand the diagnosis. So it's a bit of a different approach to family therapy than you might see outside of a hospital system, but it can really be essential and really impactful. I mean, for one thing, the whole point of residential is we're going to actually remove you from the broader world where there are stressors that you cannot manage right now, whether it's stressors of work or home life or some other thing. We're going to create a new kind of microcosm for you that is healthy and where you can get stronger, right? And then we're going to gradually return you back to the broader world that's much less predictable. So if there's anything we can do to make that broader world safer or more compassionate or more predictable, that would be a good idea. So working with the family on more than just your traditional OCD, accommodation of rituals and things like that. And I'll get involved in that sometimes, or members of my team will get involved in that sometimes, but in a much more traditional family systems sense of like really helping people to communicate better, understand each other better, know when to go to each other for help, know when to set boundaries with each other. That's super important. Really helping to train families to step out of the therapist role and back into the role of mom or role of dad. And again, that's something that can be flexible. Some of the people here do family therapy, every other week or something, and some of them do it multiple times a week. Again, we're very interested in looking at each of the diagnoses and challenges as stars in a constellation, and then looking at like, how do we take care of the whole person? The retreat is a very holistic place. There are times where you say, and you see it's an outpatient on, it's like, oh, I'm treating this person with OCD, but every time they do exposure, they have a shame attack and they want to cut themselves. I'm going to refer them over to some DBT person. And when they stop having that problem, they can come back and work on the OCD. And it's not to say that never works, but the problem there is like you're an OCD therapist in outpatient, siloed, you're trying to stay in your scope of competence, and you can't help this person in that moment because you don't have all of the skills known to man. And if you did, you might not be a great OCD specialist because who has time to get trained in everything? In this environment, more often than not, if you have a challenge, we have a person who can help you with that challenge. So we can come at you both in an organized, timely way and also all at the same time, just sort of, based on what your needs are. We didn't mention this already, but neurodivergence can often play a big role in why people maybe haven't really gotten their needs met because they didn't understand the role that autism or other forms of neurodivergence were playing. And so they're increasingly trying to express to the world, I'm not okay, but they're not able to express it in ways that many people around them can appreciate or understand. And so they're coming to this system and they have OCD and they have trauma and they've developed some personality disorder traits, but guess what? Maybe if the whole time they understood that they were neurodivergent, they could have gotten some skill development in other areas that would help them to communicate with people. They could have developed some self-compassion for understanding why they might miss certain things or understand themselves in a certain way in relation to other people that seems to be different from the other people that they're around or different from their family members. So that's another thing. We have a Center for Autism here at Sheppard Pratt. And we have autism experts who, again, kind of come onto the unit, take a look, help us understand, is this a missing piece of the puzzle? And if it is, how can I really help this person go back into the world, suffering less, better able to communicate, better integrated in family, work, relationships.
Yeah, I like that. That's a good illustration. And how have you found it? Obviously, it's been a while now you've been at Sheppard Pratt. How long have you been there?
It's been about 4.5 years now. Yeah.
Oh, wow. I didn't realize it was
I,
that
I
long.
think
Okay.
I think it might actually, it's a little embarrassing, but it might be the longest job I've ever held.
Okay.
I've moved around a bit in my life.
Yeah. Okay. So, okay, 4.5 years. Wow. So maybe this question is a bit late now, but we can answer it. How did you find it initially going from private practice to, running your own business, doing private practice to now, running this OCD department at Sheppard Pratt? And then how have you found it now? Do you miss private practice? I'm sure there's elements, but
I think in private practice, I can honestly say there are times where I miss the simplicity of it. I just sort of go and I see my patients and I come back, and had a small team and had an intimacy to it. It was very, very simple. It was a nice life. But one of the reasons I was so attracted to this offer to come to Sheppard Pratt was that I have this craving for, okay, so what's next? What's the next level? I'm not saying that's always a good thing. I mean, sometimes I should probably just stay where I am, but I do have this tendency to be like, okay, this is good, but how can we make it better?
yeah,
How can I help more people, or how can I help people that I couldn't otherwise help? One of the things that was frustrating in my outpatient private practice was what we talked about before of kind of like, okay, this person has a problem I really believe I can help them with, but they also have two other problems I really believe I can't help them with. And I don't know who can help them with it. Maybe this guy, maybe that lady over there,
yeah,
we give it a shot, right? But they're like way over there and then they cost extra and all this stuff, right? So working in a team environment with people who have different kinds of expertise is really, really gratifying because I don't feel like I have to know everything all the time. And I can be honest without being ashamed of like, I don't know, right? And to have somebody else say like, well, maybe it's this. I'm like, oh, we can look at it that way. So yeah, I mean, I think I don't know, maybe in the few years before retirement, I'll go back to like a part-time private practice or something like that. But I'm glad that I made this shift here. It's definitely a different workflow, but what I like about this too, besides all the collaboration with my colleagues, is that it is different. It's not just patient after patient after patient after patient, and then I'm thinking, oh, I got to hire another person so that I can make them see patient after patient after patient and make money off of them and build this sort of never-ending pyramid. No, I can actually kind of stay where I'm at for a while and just, in addition to doing the clinical work that I love, do some world building, right? Okay, we know we're helping a lot of people at the retreat. We know we're helping a lot of people at the Center for OCD and Anxiety. How else can we help a lot of people? What other programs, intensive outpatient programs or, different types of groups or things like that, or different skills. Recently we got very much into radically open DBT and noticing how that can be helpful for people with maladaptive over control. Like, oh, that's interesting. Maybe I can get my team trained in that, and we can kind of incorporate that into our work. Okay, cool. Now, what's the next thing? And there's a quality of there's some. It's hard to put into words, but there's something so gratifying about being involved in really knowing that you were instrumental in reducing somebody's suffering, and they're going to go out into the world and not just suffer less, but also cause less suffering to others, right? They're gonna be interacting with others in a way that they might be paying it forward. And I hate to use the word addictive because of its connotations, but there is something kind of addictive to it, right? Like, how can I help more people help more people? And I did feel limited in my ability to do that personally in outpatient private practice, and I feel somewhat unlimited here. In that sense, limited in the sense that I can't just do whatever I want. I work for a big system and there's plenty of people above me, but unlimited in the sense of I'm now positioned where if I have an idea, I don't have to just shrug it off. I can write it down and think about it and start talking to people about it and see if it has wings.
Yeah. Yeah, I like that. I like that. And similar why I still do the podcast. I love doing the podcast, but equally I love being a therapist probably slightly more than being a podcast host, as much as I do enjoy the podcast. But the reason I keep doing it is because I can help more people through the podcast than I can as an individual therapist. So it's that, like, sometimes we make choices based on our values, and yours and mine is probably helping people. So Sheppard Pratt allows you to do that more effectively, as does the podcast for me.
Yeah, that makes a lot of sense. And, I'm not telling you something you don't already know, but it is true that your podcast helps so many people that, they're missing information about OCD or these questions about, well, like, why does someone come to residential? Well, there's some piece of the puzzle that hasn't been met. Well, sometimes that piece of the puzzle is they need a higher level of care or a different type of care. But sometimes it's just they don't have information. They don't know what they don't know. And listening to your podcast opens them up to do that. So I've been wondering that about you, because you've been doing this podcast for a while and it's so successful. And
9 years.
And now I know you're working as a clinician, and I was wondering if you were thinking about, retiring it at some point. But I could imagine it'd be something very difficult for you to let go of, because it must be a great source of joy for you.
Yeah, thank you. I mean, I fantasize about retiring every week, but I'm too stubborn to quit, probably to my detriment. But no, yeah, I'll keep going for the time being. It makes me a better therapist as well. So, but yeah, I hope as part of Sheppard Pratt's therapy program, there's an hour a week of podcast listening time for OCD stories. You can play each week's episode. Listening party you could do maybe on a Sunday at Sheppard Pratt.
That's actually not a bad idea. I'm always kind of thinking about
and then debate
additional programming we could provide for people, both with and without OCD, at other times, right? So it's like they're in programming 9 to 5, and there's only so much therapy you can do. And I'm not saying that we want to overload them, but the weekends can be a little bit quieter, or the evenings can be a little bit quieter. And I like this idea, though, of like, listening parties or something like that. Yeah, I'm trying, just so I'm trying to, book club's a good idea too. I'm trying to get people here to get more into just meditating without instruction, without the yoga, without the teaching, but to just sit, which, there's plenty of reasons why people find that difficult, both physical and mental. But I'm trying to create a space here for people, not just the patients, but also the staff. So I sort of threw something on the schedule really early in the morning on a day where we have an 8 o'clock meeting. So it's 7:30 in the morning on Wednesdays. And I put signs up everywhere. And it's just been me and one of the social workers meditating every week for a while. But I still think one day it's like one patient's going to walk in there and be like, all right, I'll sit, and then another one. And I just have this fantasy that I'm going to have a group, a little Sangha here at the retreat. And I'd love that to just be more like a part of the culture of, we could just meditate without it being therapy. Yeah. We'll see if I pull that off.
We'll keep going. So that we've got a minute. Is there anything else you wish you could have said today?
Well, many times I've had the good fortune to be on your show, and then you ask me the billboard question, and I'll be like a deer in the headlights, like, you're strong, good luck out there. I can't think of anything really cool. So I was thinking about it before today's discussion, and there's this statement that's just been coming up in my mind a lot lately, that's been helpful in that space between being triggered by something and feeling like I have to do something to get away from the uncomfortable feeling, whether it's a compulsion or reassurance seeking or sending that one more email or like trying to fix a problem that I actually just need to let it be. I've been thinking a lot. What I've been sort of allowing myself to think is, I will tolerate this experience. I will tolerate this experience. This idea of, there's something in me that's like sort of strangling me from the inside, and I want to get rid of it by talking about it or ruminating about it or checking in with it to see where it is, and not tolerating it and not saying, you know what, this is hard and I'm going to just let it be hard. I'm going to not run from it. I'm not going to flee from it. I'm going to let it just be something that is. And so I've, in my personal life, been working on doing more of that, of just, instead of saying I'm going to fix it, saying I will tolerate this, and throwing that out to your audience is something to try on for size for, it doesn't work for everything, but it might work for something.
Yeah, I like that. And that, you've just summed up ERP basically, right? I'll tolerate this. To some extent,
right? I'm willing to be in this experience, and I'm not going to, avoid it with compulsions. Yeah,
exactly. Well, thank you so much for coming on to talk about residential programs generally, and then Sheppard Pratt. Hopefully it's helped some people listening who are kind of on the fence or unsure or didn't even know it was an option. So, I appreciate that. And your time as always, Jon. Thank you.
Always a privilege to be on your show. Thanks for everything you do, Stu.
Thank you for listening to this week's podcast. And thank you to our Patreons who helped make this episode possible. And if you would like to find out more about Patreon and the rewards and benefits, then there will be a link in the episode description. If you enjoy the OCD Stories podcast and would like to support us, please subscribe and rate the show wherever you listen to the podcast. And thank you to NoCD for supporting our work. If you want to find out more about NoCD, head to go.treatmyocd.com/the OCD Stories or click the link in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.